Well, I feel so woefully unprepared to walk onto this stage. I mean, I have neither baseball hat nor bow tie. I feel like I've shown up at a gunfight armed with a bowel grasper or something like that. But I would like to thank Brian for giving me the sexiest topic I've ever been asked to speak about, privileges for robotic hernia. Thank you. So, if anyone needs to take a nap, fall right asleep right now. It's no problem. I will not be offended. So I have been asked to take the argument that separate privileges for robotic-assisted hernia are necessary. But, you know, I think there's even an implicit bias in the title of this session. And I want to be completely objective here because I'm just going to present objective data to you so you can realize that I've got no videos, I got no bow tie, I got nothing. I'm just giving you the facts. So in hopes of being completely objective, let's see, is my clicker working here? I think that we should also call it robotic impaired hernia. It can be either assisted or impaired. So let's be completely objective and we can go either way. And by that same token, yes, I will give you my disclosures. I did receive some travel support from Intuitive when I was learning how to use the robot, but because I didn't use enough of their product, they withdrew travel support from my fellows, so I'm equally biased in both directions. And you can see the bottom point on my little disclosure there. So let's talk a little bit about credentials and privileges, because we always use those words, but a lot of us don't really know what they mean. Are they the same? Are they different? Can you use the terms interchangeably? Well, what are credentials? Credentials is your resume. It's who you are, it's your training, it's the collection of evidence supporting your education, your training, your licensure, your clinical experience, your overall qualifications to do something or to use a certain tool. That's different from privileges. Privileges isn't you. Privilege is what your hospital gives to you. It's a permission granted by your hospital to do a particular group of services or procedures. So a lot of people would say, oh, I'm credentialed to do robotic hernia, but that's really incorrect. If you want to use these terms correctly, you should say that after the hospital reviewed your credentials, they granted you privileges to perform robotic hernia. So in order to understand this whole concept of, you know, do you need special privileges in order to do a robotic hernia, you have to understand two important concepts. There are different kinds of privileges. We're mostly used to specialty-based privileges, but there are two different kinds. There's specialty privileges and there's device-based privileges. So what's an example of a specialty-based privilege? Well, when you showed up at your hospital, you were probably granted something similar to what they call in my hospital core general surgery privileges. What does that mean? Well, you finished up, you're a board certified or a board eligible surgeon, you completed an accredited general surgical residency, and they review your credentials and grant you these privileges, which allow you to do a broad range of abdominal procedures, other operations, thyroid, rectum, everything in between. It allows you to use a diverse set of tools, so you can use open instruments, laparoscopic instruments, electrical instruments, sharp instruments. It's based on the premise that general surgical residents are generally trained to use a broad spectrum of different tools and a broad spectrum of different procedures. So this is an example of a specialty-based privilege. Now, it's different, for example, from medical laser privileges. So again, at Mount Sinai, you have to, if you want to use a laser in one of your operations, you have to get specific privileges to use a medical laser. And it's a very specific privilege to use one tool for one thing. So for example, if you want to use a specific laser, you have to prove that you have taken a course so you can safely use it and you know how to wear the safety goggles and all that. The permission to use this type of laser may not even apply to other types of medical lasers. So this is an example of a device-based privilege. How do you get it? You don't have to do a whole residency in laser surgery. You just prove that you attended your half-day laser safety course and that you know how to use it and you've been in-serviced, and they will be granting you privileges to use this specific device. So that's an example of a device-based privilege. So we have to ask, should robotic privileges, and I'm arguing that robotic hernia privilege should be separately granted. Well, should robotic privileges be specialty-based or should they be device-based? Is robotic surgery a separate discipline or is it just a tool that we use in order to complete an operation? And my answer would be that it depends. It's not a clear yes or no. And what does it depend on? Well, it depends on whether the person who's applying for these privileges already knows how to do advanced, non-robotic MIS techniques. So I think we can safely assume two things. If someone is coming up to you and they say, hey, I want to do robotic hernia, whether it's inguinal or ventral or whatever, you need to know two things. Number one, you need to know the technique. I mean, we've established that. You need to know how to safely and correctly perform a minimally invasive hernia. And minimally invasive means you're using trocars, you're using video to guide your instruments. So you definitely need to know the technique. I mean, you'd be an idiot to say that someone who doesn't know the technique should be granted privileges. Well, what about the device? Well, obviously you have to know how to use the device. You're not going to grant someone robotic privileges if they're not skilled in using the robot. Of course, that doesn't make any sense. So, quick question. Does a typical graduating chief resident have the skills to do the technique, to do minimally invasive hernia technique? Well, it kind of depends. It depends on when you trained. You know, if you trained roughly, before 1998, you probably weren't trained how to do laparoscopic hernia. But if you trained afterwards, you probably were trained. And maybe it could go either way. But even if you weren't trained how to do minimally invasive hernia, you may have acquired those skills through additional training or experience. What about robotic skills? Does your typical graduating chief resident from a general surgical residency have robotic skills? Well, yes, there are a few isolated programs in the United States where they do incorporate robotic training as part of general surgical residency, but in general, no. Robotic surgery is not expected as a routine part of your general surgical training by the American Board of Surgery. They make a big deal about how many cases you have to do, your 750 operative cases. You have to do 150 cases in your chief year. You have to do 25 cases of surgical critical care. You have to have 25 cases as a teaching assistant. Is there any mention about how many robotic cases you have to do? Clearly not. Your average, the vast majority, I shouldn't even say your average, but the vast majority of graduating chief residents are not going to have robotic skills at the end of their training. So it kind of brings us to this 4x4 grid here, and I think we can look at each of these corners here and figure out what goes in each. Should you be allowed to do robotic hernia without separate privileges? Well, let's look at whether you have robotic skills, yes or no, and whether you have minimally invasive hernia skills, yes or no. Well, clearly, I think we can all just say straight out, if you don't have robotic skills, you shouldn't be allowed to do robotic hernia. That's just clearly obvious. Well, what about if you do have robotic skills, but let's say that you've never been trained how to do minimally invasive surgical hernia. Let's say you were a general surgeon who trained before 1998. Should you be allowed to just walk in and do a robotic hernia? No, absolutely not. You should be required to have separate privileges. Maybe in this one situation where you already know how to do advanced laparoscopic hernia repair and you're already skilled with the robot, I will grant you yes. In that one situation, you do not need separate privileges. It's okay. But if you look at this chart, I mean, what do we have? We have 3 out of 4 scenarios we can clearly see you should not be allowed to do hernia unless you have special privileges. So 75% versus 25%, I think the answer is clear. Thank you.
Excellent argument for what is perceived by some as a barrier to adoption. So now we're going to hear why none of that is needed. Dr. Matthews.
So I want to thank David and Brian for allowing me to participate today. I also want to thank Dan for supplying all the slides to my talk. I'll show you why that is. Ed, can you come up here and run my slides for me, please? These are my disclosures. So Dan talked a little bit about the difference between credentialing and privileging, and I won't go into that anymore, but certainly in recent years there's been more controversy as manufacturers get more into the role of training, of what role do they really play in the whole credentialing and privileging issue. And there was what some people call a landmark case of a plaintiff coming against a manufacturer as it related to robotic surgery around this issue. What liability did the manufacturer actually play in the medical malpractice suit that was brought against the physician in the hospital? In this case, actually, the plaintiff's attorney argued that the company had failed to provide the attending surgeon with sufficient training and oversight to properly perform this procedure. And the plaintiff also alleged that the company failed to adequately warn the surgeon about risks, contraindications, and so forth as it related to using this device. This was actually a defense verdict, and it's in appeals. In this article that was in JAMA about hospital credentialing and privileging of surgeons, a potential safety blind spot, really goes into this area around negligent credentialing and what roles does the hospital play, what role does the physician play in this whole issue. So one thing you have to realize is the robot is not autonomous. So the robot is actually a tool that we use to perform a therapeutic procedure. Because it's not an autonomous device, we see this as a general use tool. So very similar to a lot of the other tools that we use in surgery, and you can think of all the other applications where you learn to use a tool and then you apply it in GI surgery or hernia surgery or a solid organ surgery or so forth. So this is why these don't require separate privileging as it relates to a specific technique. So these are some of Dan's slides that he presented to the FDA at the meeting that was brought up earlier about level of evidence used to justify general indications for robotic surgery. And certainly he went through the argument of what is a general use tool and how is a robot very similar to that. And essentially showing that what they do at his own institution is that that you get privileging for robotic surgery, and then it's the surgeon that has the ability to apply that tool to different types of indications. So what is a general use tool? Well, it can do a lot of things, and again, it can grasp, it can cut, it can apply energy to tissue, it's stable, so it does a lot of things that a lot of other instruments can't do. What about the meeting that we're at and the society that actually sponsors this meeting, and that is SAGES. And Dan chaired the consensus document on robotic surgery that was between the SAGES organization and MIRA, looking at this issue of training and credentialing. You can see from the first one, it says, how should training for robotic surgery be accomplished? What is the appropriate process for credentialing on the robot? And it talks about uniformity and standards, and I want to read this first sentence. It says, uniform standards should be developed which apply to all medical staff requesting privileges to perform procedures using these technologies. So it doesn't matter if you're a urologist, you're a general surgeon, you're a thoracic surgeon, the standards should be the same in terms of becoming privileged to use the robot as a general use tool. They talk about minimal requirements for granting privileges, and certainly on in real world terms, credentialing and privileging is an institutional responsibility, and it may be different from institution to institution. They also highlighted some things about what happens if your experience is in your training, what happens if your experience is after your training. So how do you handle the requirements for granting privileges? And the pathways are different in terms of getting the appropriate experience to be granted privileges to use the robot as a general use tool. This is an article that was published in Surgical Endoscopy, and I'd certainly encourage you all to read this. And it's the European Association of Endoscopic Surgeons consensus statement on the use of robotics in general surgery. And they highlight in this that a curriculum of basic skills that all surgical specialties can use to train and assess the performance of surgeons desiring to engage in the practice of robotic surgery is the pathway towards privileging. And this shows some of the resources that they actually use for this. This is the discussion. This is from the discussion paper of the FDA summit that they had last summer, and also highlighting the issue that the robotic-assisted surgical devices are in use in the operating room. It's one part of the whole component of the operative team. It has been clear for general surgery indications with pre-market testing demonstrating the capability of performing representative tasks or procedures. So it's not specific to the actual operation you're doing, but representative of those in total. What is the American College of Surgeons' stance on this? It is very, very vague, and Dr. Sachdeva gave a talk at the workshop last year and kind of goes into this, not taking a stand of it's actually procedure-based or that it's not procedure-based. So stay tuned, and I'm not surprised with the conservative nature of the college taking this type of stand. Well, Dan's institution, this isn't him in himself, these are other people at the Mount Sinai institutions, wrote a paper on a primer on best practices for privileging and credentialing in robotic surgery. I believe this was urologists and thoracic surgeons. And demonstrate a pathway, and a pathway is based on a competency assessment, so going through a pathway prior to actually using the robot, continuous assessment as it relates to continuing medical education, competency as it relates to outcomes of doing the robot, the actual number of cases you do on a yearly basis to maintain your privileges, but again is agnostic as it relates to the actual procedure. So I would argue that separate privileges for robotic-assisted hernia repair are not necessary at this time and certainly in the near future. Thanks.